have been developed. And then also we'll do a case scenario, and then we'll do a SMARTCARE demonstration. And then we do have people on the call that are experts that will help to answer some of the questions that the network might have. And so I would like to thank everybody that is on the panel. I did mention that we've been joined by Machalo Mbale, Timothy Chabu, Christopher Mugo, Wali Achilea. Please feel free to come in and make a comment as need arises. And so we also have Dr. Bosco and Sachim Kasianyinda also, who will be panel experts. So without further ado, I am going to invite Dr. Tommy Sajisa just to introduce himself and then just talk about a bit about the organization that has come on board to support the SMARTCARE work since Broadridge has since left. Dr. Tommy Sajisa.
Thank you very much, Dr. Zambo, and good afternoon, everyone. Yeah, maybe just a small correction. SMARTCARE system. Like how it was introduced by Dr. Jambo, I'm not alone on the call. I have the experts that are going to help me in attending to some of the feedback that is going to come from you. The ART forms have been in existence from the time that the ART started. And all they have been doing is just undergoing revisions, depending on the guidelines. As the guidelines are set by MOH, the forms also change. And then once they change, then they are taken to the developers. And then the developers also change them into the system. I must say that the ART module in SMARTCARE is the highly developed or the highly robust module because the ART forms that are on paper are exactly the way they are in the system. And so some facilities have been able to transition from eLast to eFirst because all you do is just make an artificial shortage of the paper forms. And then because you want to attend to the patients, you will not say, no, because we don't have the paper forms, so we're not going to use the ART forms. So all you do is just go into SMARTCARE, and the same initial history, the same clinical follow-up, the same eligibility initiation, whichever service your client has come for, then you are able to use the form in the system. So you will see that as time goes by, you will stop using the paper forms, you just be using the system, and then you would have already become eFirst in that facility. Having said that, I'll then go into, I'll share with you the paper forms. The first forms that we just used in SMARTCARE or in ART, then the ones that were revised in 2013, then finally I'll show you the ones that were revised recently. That was last year in January 2020. Those are the new forms that we're talking about. So allow me to share my screen with you just now. Then you can go to this one. Kindly allow me if you are able to, let me know if you are able to see my screen. There's no response from anyone. Okay, so we will start with, hello?
You can see the screen. That's wonderful. Thank you so much.
Oh, thank you. So we'll start with the first forms that we were using. By the way, we'll just look at the 4 forms. As you are aware, there are more than 10 ART forms. But for the sake of this session, we're only going to look at the IHAP, the patient locator, the clinical follow-up, and the patient status form. So the first form that we used was this one. If you check just below here, it is written initial history and physical version 3.20.6. So these are the forms that we used first, and they start from the demographics, that is the date of the interaction, the patient ID, which is the new PIN that the client is given on registration, and then the patient's name, the patient's first name, and the clinic code. So it will start from background. Under background, you have the sex, which is the gender, the NRC, the date of birth, and whether the date of birth is an estimate, and the age. Then you would go on to write whether the patient has disclosed status, and if they have disclosed to who, and the status of the partner, whether deceased, alive, or dead, or no partner. Then you would go into their status, is it positive, negative, or unknown, then where the patient was referred from. Then from there, you'll go into past medical history. The past medical history then was limited. It had only those about 8 conditions. That's the liver disease, diabetes, the kidney, the lung, STI, heart disease, hypertension, and psychiatry. Then you would ask whether this person was smoking, and if they were smoking, how many cigarettes per day, and for how long. And then alcohol, again, the same thing. Then if there are any other things to describe, you would describe it in those lines there. Then you would go into TB history. Again, you can see that the TB history there was just asking whether the client had the current TB, and if they were they on medication and what type, when was the TB diagnosed, and then the past TB episode. So that was all that was captured on TB then. Then you go into family planning. Again, those few items on family planning. And then you go into obstetric history to ask whether the patient was currently pregnant, whether they were breastfeeding, and how many pregnancies have they had, how many births, how many children do they have, and so on. Then PMTCT. Then you had the PMTCT drugs there, which were NVP, AZT, and the other. Then you'd go on the ARV drugs. The ARV drugs were the NRTIs, the NRTIs, and the PIs. then other medications there. So that was history. You were taking history for the patient, the presenting complaints. So there were that list of complaints there. That was there then. Then review of systems from constitutional all the way down up to other. Then you do the physical examination. And by the way, this method that we were using was still based on the SOAP approach, where you first get subjective data from the patient's own mouth, and then you go into objective data where you examine and so on, and then you do your assessment and you do your plan. So you do your physical examination, the same height, the same weight, the BMI was calculated, the BP, temperature, and then you look at the skin, the eyes, and so on up to neurological there. Then you would go to WHO staging, the usual stages, stage 1 up to stage 4, okay? And then you determine what is the WHO stage on that day. Then you go into the functional status, whether healthy, able to work, whether sick, able to work, whether sick and able to work, whether bedridden. Then you go into assessment to check if they had malaria, if they had STI, or if they had the TB suspect, okay, and all those other diseases there. Then you went into the plan. Now, remember when we just started ART, ART regimen or initiation on ART was based on eligibility. So the IHAP then was just assessing for eligibility, because not everyone who was positive then was put on ART. So you were to be assessed for your CD4, your viral load. Remember that at first it was 250, then it went into 350, I think, if I can remember very well, then 500, and then came the test and treat, which is now being used now. So the IHAP then had no starting ART. It only had the assessing for ART eligibility. Then finally, you do your prescriptions, and then you give an appointment. So that was the first form that ran for about 10 years or so. Then in 2013, there was a form that was revised. This one was called, let me just check. This one. It was called IHAP, sorry. Yeah, I think it is this one. It was called version 4.5, CG 2013. So this is the one that came that time in 2013. And let's look at the revisions. So on the revisions, you see that the demographic data is still the same. The addition was on the care card. So the care card now had a number, and that number was attached to the patient ID, which was the new PIN, and then the serial number. Okay, then the name, the date of birth, the gender, all those were the same. The NRC was the same. But you can notice that the background that was on the first form was removed. So this particular form started from past medical history. And then the past medical history had the diabetes, the kidney, the hypertension, and psychiatry. Then you went into obstetric history, and then you ask about LMP, expected date of delivery, and whether the client was breastfeeding, and if they were breastfeeding, was the child tested, and what was the result, and then whether they were screened for cervical cancer. On the first form, cervical cancer screening was not there. Then in the family planning, you will notice that here it has changed to prevention. So on the second form that came, the family planning was changed to prevention, but the commodities for family planning were still the same. Then he went into sero status and disclosure. You say whether it's HIV-1, HIV-2, or HIV-1 and 2, and then the disclosure there still continued. And then prophylaxis was also added. So there was Septrin, fluconazole, and Fancida, and isoniazid. They were added on this form. Then you went into drug history. Again, there were the TB drugs, the ARVs, the prophylaxis, and also the drug allergies, if the patient had any drug allergies. Then you went into presenting complaints. Again, on the presenting complaints, there was the always screening for TB, the cough, fever, night sweats, and weight loss. And then if one or more symptoms was present, order sputum for AFB or gene expert. Then you went into review of symptoms as usual. Then the physical examination, the whole clinical staging is the same. Then you went into assessment. Now, the assessment here included the presumptive TB and the presumptive STI. And then you went into the plan. Now here, the test and treat had started. So your plan included actually starting ART. So you can start ART. You could start ART using the IHAP. Then you went into prescriptions, TB drugs, non-ARVs. Then you went into investigations. And then the ARVs there. The first line, the second line, according to the guidelines then. So this is the second form that was brought on the scene. Then now, the new form that we're talking about is this one. This one, even the title itself has changed from just initial history and physical to adult initial history, physical, and the initiation. So the demographics here is the same. The care card number is included, the serial number, check digit, but they have included the nickname because that is the name that people are commonly known with in the compounds. So the commonly known name is also included on this new form. So you go into the HIV test. The 1, 2, and 1 and 2 HIV type is still there, but we've included when was it tested. The date of test is also there. Another interesting addition is the recent test. So you do the recent test and say whether this test is recent or this status is recent or it's long-term, and when was it done. So this is an addition on the new form. Then you go into the medical history. So on the medical history, you will see that the current TB, if this client has got TB, you say the date when it was diagnosed and the mode of diagnosis. So the mode of diagnosis has been added. You have to say whether it was diagnosed by microscopy, by X-ray, by expert MTB, expert RAF, or culture, or LF LAM. Then you have that list of diseases on the past medical history there, from recurrent pneumonia up to asthma, all those. So you say whether the patient has had those or not. Then you go into the past TB episode. When was it diagnosed? And what type was it? Was it extrapulmonary or pulmonary? And then was the ATT completed? And if not, why? So that is important. So you've seen that here, TB has been taken care of because we have to talk more about this TB, whether current or whether past episode. And if it was past, was the ATT completed? So those are the additions. Then you go into the drug history. On the drug history, you'll notice that apart from the TB drugs, if this patient has TB, there's also TPT. You'll see the TPT eligibility down when we reach there. But here, if this person has also been on TPT drugs, you'll say which drugs they have been on. There's INH, 3RH, 1HP, 3HP, and other. This is obviously to prevent latent TB. So the ARVs, again, you've got the NRTIs, the NNRTIs, the INSTIs. Remember that we have got dolutegravir now and raltegravir, which were not there then, and then the PIs. So there are now 4 groups or categories instead of 3. Then you go into TB screening. presenting complaints and review of systems. So you have seen that here, they have done some kind of merging. So you screen for TB by looking for those symptoms, the cough, the fever, night sweats, and weight loss, and chest pains. So now here, if there are no symptoms, you check for TPT eligibility. But if there are any symptoms, then you evaluate for latent TB. Then you go into presenting complaints where there is fatigue, rash, sores in the mouth, diarrhea, swelling of the lymph nodes, the vomiting, sores on private parts, and so on. And then you go into the review of systems, which are the same ones from constitutional, GI, neurological, cardiorespiratory, GU, and up to the last one. So now from there, you go into family planning. And on the family planning, we've included the permanent, the vasectomy and the BTL. Remember, on the other forms, it was just other, then you specify. But here we've put it out. So vasectomy has come out on its own. So there's also the emergency PO there, which is commonly used these days. Then there's also the natural method and the IUD, IUCD, and the injectables. So the family planning or the prevention methods have been expanded. So if there's no, if the patient doesn't need family planning, if no, does the patient client need family planning? So this is counseling. So if yes, refer for family planning. Now, on the obstetrics, the title is not there, but is the patient currently pregnant? That is obstetrics. So you say yes or no, then you put the LMP. Is the patient currently breastfeeding, yes or no? Now, has the patient been screened for syphilis in this pregnancy? So it's just not a matter of being pregnant, but has the client been screened for syphilis? And if syphilis is present or is positive, has the patient received the dose of benzene penicillin? So this one has also been expanded to know more about this pregnancy. Have the major things been done, like syphilis screening? And if it's positive, has the ritapen or benzene penicillin been given? Then he also screened for cervical cancer. So the cervical cancer all along we have had the VIA, but here we have included the HPV DNA as a method of screening for cervical cancer. Then you go into your physical examination, you do your general, you do your vitals, but include also the bedside lab results. So the HBsAg, which is hepatitis B specific antigen, the urinalysis, the RST, and the pregnancy. So if those results are there, they're also supposed to be included. Then you go into the examination. The assessment has got the presumptive TB and the presumptive STI, and you do your staging, either 1, 2, 3, or 4. Lab results have also been expanded. So we have got the expert MTB, the RAF, which were not there then, the HB, SAG, the serum creatinine antigen test, all those have been added here. For the CD4 and viral load, you include the collection date. And then these are automatically populated on the summary sheet, HIV summary sheet, which comes out as a patient report in the system in SMARTCARE. I was talking about the eligibility for TPT. It is here. So you ask or you assess whether the patient, rather you just ask whether the patient has been on TPT in the last 3 years. And if they have not been on TPT, or if they have, are they eligible for TPT today? Is the patient eligible for TPT today? So you say yes or no. And if yes, if eligible, have you provided TPT today? So it has to come out, actually, not just a matter of assessing, then you leave it there. So you have to make sure that the TPT has been given today. Then you go into planning. So you'll see that the planning here has actually expanded to include a lot of other things. So there's the same TPT I'm talking about, is there, the CTX is there. Then there is the enhanced adherence counseling. The ESC has also been included. The fluconazole preemptive therapy, fluconazole, you either provide it, you continue or you discontinue. Then you can either start ART, you can continue ART, you modify or you discontinue, or you refer to the next level of care. Then you can start in DSD using the IHAP, and the type could be community-based or family-based, or whether you transfer to the mainstream care. Then there's also a question of how to manage advanced HIV care. Does the patient have advanced HIV care? Say yes or no. And then there are those 3 tests. If it is yes, have those tests been done? So there's the cryptococcal antigen test. Was it done? The LF-LAM test, was it done? And the chest X-ray, were they done or not? Then you go into the investigations. So investigations also have included the others that have not been there, like the expert MTB, RIF that we're talking about, the LF-LAM for TB, advanced TB, the HPV DNA for cervical cancer, all those, the serum creatinine antigen test, all those have been included, including the lipid profile. So we have got more investigations there now. The referrals have also been increased or more added to include disclosure counseling, the EAC, the SETA, and so on. So all those were not there. Then the prescriptions, again, according to the guidelines. So you have your non-ARVs, the anti-TB drugs there, the combined and the singles, and then the prophylaxis, and the TPT, INH, 3HP, IHP, 3HP, and so on. Then for the antiretrovirals, again, the first lines and the second lines have changed according to the guidelines. So you have your TDF, 3TC, and DTG there. You have your TDF, 3TC, and DFV with 400 milligrams low dose is there for efavirenz. Then you have your TAF or TAFED, which is there. So those are the first lines. And then the second lines, you have all those there also. And then finally, you say how many months the ARVs have been prescribed for. When is the next clinical appointment? Is it after 1 month, after 2 months, after 3 months, and after 6 months or other? Then when is the date of the next clinical visit? So this is the new IHAP, which is now into SMARTCARE. So
thank you so much. I think at this point we can accommodate some questions from the network. I know we may have been those that have been able to follow, just so that we don't lose anybody. Kindly raise your hand and just show it there on the, we'll be able to unmute you if you would like to ask any questions, any clarifications. Thank you. All right, so allow Chilenge, then Danny, then Hagri to ask their questions. Chilenge, Danny, and Hargreaves, go ahead in that order.
Good afternoon, Dr. Chira here. For the preventive therapy, for those that are eligible, there were times when we could not initiate because we had drug stockouts and there were other reasons at times. So can we have like a column where we can actually write reasons for not initiating a client on a preventive drug?
All right, take a note of that proposal. Hargreaves, or is it Danny? Danny, then Hargreaves.
Good afternoon, Doc. Dan Mulenga.
Go ahead.
I would like to ask a question, or I don't know if it's a concern about the research test. In the facilities, we don't receive results. So how is this necessary to document if it's a recent or a long term? Thank you.
All right, thank you so much. That's a program question. So we'll ask a program just to advise on that one. Take a note. Hargreaves?
Good afternoon, Mr. Kozian.
Hi, good afternoon. Thank you.
First of all, I would like to say that the form is quite comprehensive. It's good for us to have most of the data. I'm happy that we have come this far. However, I just wanted the clarification on I've noticed that ESC has been included on the initial form. Is this meant to cater for the trans-ins? Thank you.
So ESC on the initial form. All right, thank you so much. Well, with those three concerns, we invite Tommy just to give responses, except the second one. We also have people on the panel that can also contribute to some of these responses. Go ahead.
Thank you very much, Doc. So the preventive therapy, you made a good suggestion that there are times when it's not given because of stockouts or maybe other reasons, and you have suggested that we put maybe a text box to specify or to give a reason why, if it's not given, why was it not given? As we're aware, these forms are done by a team of experts from MOH. For us, we'll just get feedback and then we'll submit it to the team of experts that are going to work on the form. And once the forms have been revised, that's when they are brought to the developers at the organization I work for to then implement them into the system. So the short answer is that yes, we have taken note of that one and then we'll submit it accordingly. The recency test, Doc said I leave it because it's a program issue. What we have done in the system, when you search in the lab, in the investigations, you actually find recency test there. Okay, just like you find the layer determine, the bioline. So the recency test is also now there. And then the result is also there, whether it's reactive or non-reactive. And so now it is up to MOH to find the test kits for the recency test. The ESC, which as you've said, it has been put in the IHAP, you will notice when we go to the clinical follow-up that it is also there in the clinical follow-up. So it is to do with adherence, counseling, and so even during subsequent visits, when the patient comes, the ESC is also part of the referrals that someone can be recommended to go for. Thank you.
Thank you for those questions. So I'll just allow 2 more questions so that we can proceed to the next form. Otherwise, we will take a very long. Dr. Bosco, maybe you wanted to make a comment or you have a question?
No, it's a comment on the ESC.
Please go ahead.
Yes, so that was a very intelligent question, actually. Remember, initial history is being administered at the initial when we are initiating a patient on ARVs, when we are registering a patient.
Yes.
Now, the question you are asking underground is how often do this initial history can be used or used in the ART clinic. So first of all is when we are enrolling a patient. Now we have patient we call the transient. A transient who come in your facility, some of them come with the result of their latest viral load. They've been on ARV for so long. They will come with the result of the viral load, and their viral load is high. Those patients, as we are enrolling them in the new facility, they are eligible to be provided with enhanced adherence counseling sessions. That's the reason we had put this in this form because this form can be also used for a patient who is a transit, who's coming back to your facility, who being transferred, either self-transfer or transfer by the facility. With the viral load result, we can actually administer, we can also administer the e-accession. Thank you.
Thank you very much, Dr. Bosco. I'll allow Maureen Mzmara and Dr. Christopher Mzungairi to ask your questions in that order.
Thank you, Doctor. Good afternoon, all. For me, it's just a suggestion on syphilis treatment. I think we've only highlighted benzathine penicillin, but many times it's out of stock. Could we add a column for other? You know, we can use erythromycin. We can also use doxycycline in non-pregnant clients. Thank you.
Great proposal. I think that one as an HIV program, I think we've taken note of it. I think it's something that has come up several times. And so we are going to take note of that and see if it can be included. Thank you very much. Dr. Mzungairi.
Hello.
Yes.
This is Joseph asking on behalf of China, but it's something to do with the back end. The front end looks beautiful, and we salute the great work done. But one thing that I've noticed is sometimes some of these clicks will be done in the front end, but the back end on the reporting part, you might find blanks. So I'm asking whether the design of the front and the thought of the back end also has been taken note of, as well as on TPT. One thing that we've noticed is it's a bit difficult for medical personnel to not or know that the client has taken TPT or not until they ask, and then a client has the right to say yes or no. So maybe it should be in form of a POP like it is for VL, where when a client is due for VL, then there'll be a POP to say this client is due for VL. That was just a suggestion as well. Thank you.
Thank you. Take note. That suggestion is taken note of. Maybe we can have another Richard Thomas and Daniel.
Yeah, good afternoon. I have 3 questions. One, under the plan, there is no provision to say we are restarting, because those who came back after stopping, reinitiating, that is not appearing there. And number 2, for syphilis, it may be better the partner also to be included, whether the partner is treated. Number 3, the resistance testing, at least maybe if we can provide some space to enter the result, instead of just saying resistance test result available. At least if there is a space, we can enter the mutations we saw for that particular client. Thank you.
Thank you very much. I appreciate those important comments. Before we get a response to them, maybe we can have Danny. Danny, go ahead.
Good afternoon, Doc.
Afternoon, thank you.
Thank you so very much. My question was actually gotten, and it was tackled by the doc when he was answering. That's the question that I had. Yes, thank you so very much.
Thank you very much. Dr. Bosco, you wanted to respond to some of these questions? Before I ask Tommy to come in?
Yeah, no, I can give the chance to other colleagues. I will come back shortly. Thank you.
Okay, all right. Yes, you want to respond to some of those questions?
All right, thank you very much, Doc. The suggestion on the Ritapen or benzathine penicillin, which sometimes is out of stock, is noted. Again, just like I said, that we will submit feedback Please kindly, let's mute our mics. Getting some feedback somewhere, a baby is crying. Yeah, so we've taken note to include other for, maybe the alternative if Bellathin penicillin is not there. Joseph, I didn't get your question quite well. The back end, you are talking about reports.
I think it's producing reports we are uploading, but are we also able to produce reports from, are they going together with the upgrade that has been done?
Yes, so each time they hello?
Yes, you wanted to clarify the question. I've just clarified. I hope I got it right.
Hello, Joseph, go ahead.
Okay. Yeah, I think that's it. So one thing we've noticed is sometimes entries will be made in SMARTCARE, but the back end on the reports, that becomes a challenge. So that's what I wanted clarifications on.
Okay. Yeah. So the reports, and also there's something that you mentioned of you gave an example of viral load. So those are called notifications. So you are suggesting that probably there's a notification, like the way if someone is due for viral load, then the system will pop up a message to say this person is due for viral load. So that is a good suggestion. It can also be forwarded to the developers so that if this person is due for TPT, there should be that notification. There were some issues on the plan. I didn't quite get the name of the person that asked. So you were saying restarting of ART.
Okay, so these were suggestions that can be included on the plan. Like instead of just to highlight, because some of them may have been joining back to restart, so that it's clear that you're restarting somebody who was on treatment for one reason or the other had stopped. So I think there are proposals to include that, and also on syphilis retreatment, as well as the partners those that have got, if a partner needs to also to be treated as well, it needs to appear. And I think those were the concerns. And then also resistance testing, that the results should be on those are in the plans. So I think those are just sort of taking note suggestions, which I think we should be able to look at a little later as part of the further revision of the forms. Yes.
Okay, thank you very much, Doc. Maybe Dr. Bosco can add on something.
Yes, just to appreciate Dr. Thomas' question, I think we've taken note. It was maybe an omission on our part. We did not put the restart, but there's a provision for comment. But in the next revision, we're going to include the restart as part of the plan. Thank you.
So there's a question here that when are we going to see these things being used? When do they start using these, and when are the forms being rolled out? So I don't know if from your end you're able to respond to that one, or it's a program to respond to this one.
Can I respond? Oh, sorry.
Yes, Dr. Bosco, can go ahead. You're better placed to respond.
Yes, actually, we expect all this form to be in use for a long time. And we will urge actually all implementing partners to ensure that these forms are in use already in their facilities, because the upgraders have been shared with all implementing partners. And for me, we expect everyone to be using this since January 2020, actually. Or let me exaggerate, or let me put it that way. Everyone should be using this. If you've not received, please get in touch with MOH. You get these forms, and you have to drop the old form we've been using, including the famous short visit. Let me mention that the famous short visit being used again countrywide in some facilities. So these are the official forms. They are supposed to be used like yesterday. Thank you.
Thank you so much for clarifying that, Dr. Bosco. So in view of time that we have, we will invite Tommy to just go ahead and present the next form. Looks like we've really run out of time. And yes?
Just a comment, sorry for the interruption. I just wanted to make a comment. The upgrades that were done, I don't know if they are able to look at the button for drug. I think the spelling is written as drug. In our SMARTCARE, it's written as drug. So it would be good if they can look at it. And then on the where is that? The same drug history, there is a part where dolutegravir and raltegravir in SMARTCARE, it's showing that they are in RTIs when it's supposed to read INSTIs. I don't know if that was also noted on the drug history, the actual SMARTCARE. Yeah, thank you.
Is that the old one or the new form?
The new form that is just upgraded, the SMARTCARE itself.
All right.
The copy version, yes.
All right, thank you very much. All right, so I think after this question, then we will just move on to the next one. I know we have a lot of questions, and then now allow Tommy to pick it up. Go ahead, Tom.
Thank you very much, Doc, and thanks, Danny. It's good that you've already seen actually the shortfalls or the shortcomings in the system. I agree with you. The implementation of the forms, the new forms into SMARTCARE, I must be honest, were done towards the end of the project, and so there was some more speed that was applied in the review in doing these changes, and then the reviews were done. But by the time the feedback was getting back to the developers, the project had already ended. But I agree with you that before we actually roll out the new system, there should be some more review, some user acceptability testing of some kind. Some of you might be called to that activity. You go through, you make those spelling corrections. There are some other issues, like you will see when I go into the system, you'll find that on the eligibility for TPT, both of them are showing, if no symptoms, assessed for TPT. If no symptoms, assessed for TB, and so on. So there are those errors, those spelling mistakes, and so on, that were not finally or finalized when the system was being polished. So I agree with you, it will be done. Thank you. All right, so in the interest of time, you will discover that the clinical follow-up and the initial history, most of the parts actually are similar. So, but let me just open the patient locator, because this is one other important form where changes have been made. And I know Dr. Bosco will agree with me, and I would not do justice to my presentation if I didn't tackle the patient locator more than the clinical follow-up. So the old patient locator, let me just display. I don't know if you are able to see. You're able to see my form, my patient locator?
Yes. Just go ahead.
Okay. Yes. So here, if you see the type of entry, you will discover that there are only two types of entry. There's a new patient and there's a transient, and also updating the information. As you know, the patient locator and the registration are related. So if you enter a lot of details actually on registration, you find that they will populate automatically on the patient locator. So you have the background, you have the marital status, never married, married, divorced, widowed. And that time we're even including the estimated household income per month. And actually we rebased it. And then you have the address, which I said is coming from the registration. Then the household, you had the children and others in the household. Then you had the emergency contact and the treatment supporter. And then you draw the map, you give the directions, and that's it. So that was the old, the patient locator in the version 3.26. Let me just jump to the new one. Let me skip the version 4. Let's look at the new one. So the new one has got another entry on the type of entry called silent transfer. Okay, so the disclaimer at the bottom is that for transfer patients with records, complete only parts that have changed. If transfer patient does not have records, treat as a silent transfer. On the other form, we used to treat this person without records as a transit. Was it? Let me just go back. Yeah, on the type of entry. For transfer patients with the records, complete only parts that have changed. If transfer patient does not have records, treat as a new patient. That is on the old form. On the new one, we are being advised to treat as a silent transfer. So this is the one important addition, because we've seen these patients, they just move from one facility to another without records. And we don't enter them as new patients, but as silent transfers. Then on the background, under marital status, we have included separated, which was not there on the other form. Cohabiting is also included. It's also a form of marriage, legally. Then we have the patient address. So the patient address can either be current or permanent, and then the next of kin. So the next of kin can either be spouse, parent, supporter, or patient other, guardian, neighbor, provider, workplace. Then you enter the localities, the house number or plot number, the street, the compound, the village. On the other form, we only had a chief, but on this one, we've included headman as well. Then we have included the provision for 3 phone numbers, because others have got all these numbers on all the networks. So phone 1, phone 2, phone 3, including the email address. Of course, this applies to those that have. Those who don't have, it doesn't matter. It's not a required field, such that you have to, it's a must that you have to enter a phone number or an email address. Then now, the other part of importance is the disclosure, index testing, and partner notification services. So you have to recommend the patient for either disclosure, for campo counseling, or for index testing and partner notification services, which is IT and PNS, and then you screen for interpersonal violence. Then, if this person has been offered the IT and PNS, if they have accepted, they should also say whether they have accepted to elicit the total contacts. How many total contacts have they elicited? How many of those are biological contacts? How many of those are sexual contacts? And how many of those are other? So this is also very important for upscaling the HIV testing and counseling, especially the index testing and counseling. So on the household, again, you have to give, if it's an immediate family member, you have to say whether they were tested and what was the result. And if it was positive, are they on ART, or were they linked to a provider? So that information has also to be captured. And then the other household member, again, the same thing. They ask whether they were tested, what was the result, and are they on ART, and were they linked to a provider? So that is also important on this form. Then you have the treatment supporter. Under the treatment supporter, you have the consent to be part of the follow-up program. If they agree, do they agree to be receiving voice calls, for example? Do they agree to be receiving SMSs? Do they agree to be visited at home or to be visited at work? So that information is also required. Then you have the directions, like on the other form where we provide information on how to reach the patient's home from the clinic. Then they've added the plus code this is an app on a smartphone or a tablet, which is going to help in the accuracy in locating the patient's home. So this is an app. Maybe Dr. Bosco might explain more on this one. Then you have the map that is drawn so that it's easy to locate this patient, as the name implies, that is a patient locator form. Okay, Dr. Zambo, before I go into SMARTCARE, over to you for now.
All right, thank you very much. Very, very interesting changes, and we're receiving quite a number of comments on this one. I will invite for questions from the network for the next maybe 5 minutes or so. Maybe we can ask a few questions. Any hands to ask questions there? There's one question here. They're saying, is it interpersonal violence or intimate partner violence? There's somewhere there where you're assessing. It says interpersonal violence instead of, yes, you've raised your hands. Go ahead, Sylvia. You can unmute yourself.
Thank you, Dr. Ziambo. Good afternoon.
Afternoon, thank you.
Okay, yeah, I think you've actually asked the question. I wanted just to find out if the interpersonal violence is the same as the intimate partner violence.
Yeah, actually, that's a very, very genuine concern. I'm not too sure. Maybe it was just another typo on that one. Because
it was a typo, Dr. Ziambo. It was a typo. It is a intimacy partner violence.
All right, thank you very much. Limpo, you have a question?
Yes, good afternoon. My question is on the part for treatment support that we are just from looking at. So for the questions related to the treatment supporter, when will they be answered? Because I'm sure most of the times, the once tested, the rock will be alone. The treatment support at that moment won't be with that person, unless if it's a child. So how will this part be handled?
Oh, okay. So I'm not too sure I am following your question on this one.
Okay, so when we look at the treatment supporter part, yeah. So these questions, are they for the supporter or for the patient?
These are questions for the patient. They're asking, does the patient, you want to know whether the patient will consent to be followed up and how they will be followed up, whether they by voice call or by SMS. So once you indicate here, this is the information now you provide the treatment support team to say, this patient has consented, this recipient of care has consented to be supported, and they've consented to SMS or they've consented to be visited at home. Yeah, so this is directed at the recipient of care. I hope that clarifies.
Yes, it is clear now. I thought it would still be the way it was a treatment supporter captured data for the one who will be the next of kin.
All these will be documented on the forms and in the SMARTCARE if it's e-first. Thank you very much for that very important question and clarification. There's a question here on the household part of patient locator. Do we also include, for instance, those who are already on treatment as long as they are related to the current patient? So I think that goes now to the program people. I know Dr. Sibile, you're on the call, I know, so maybe you can also intervene on some of these program-related issues. So then yeah. I think that's one of the questions I've seen in the chat. Dr. Bosco, would you like to pick that one?
Yes, Dr. Ziambo. Yes, the family members or household members, we the aim is to helping us also to do like index testing to those who are not tested, or those who tested positive to verify if they are on ART or not. So in short, somebody who is tested positive or non-positive can be put part of the other household member or immediate family members. They can too be put there. Thank you.
All right. Thank you for that clarification. If there are no more questions and concerns, may I allow Tommy to take us through to go into the SMARTCARE and see if we can upload in the next 18 minutes to see if we can work on introducing somebody in a recipient of care from IHAP maybe to Locator form. Thank you.
Thank you very much, Doc. Maybe just to add that the system was provided for linkage. So the household member who is already on ART can actually be linked to the client. So that has been provided for in the system as well. So before I go into SMARTCARE, allow me again share with you a scenario that we can use so that we see how this data is captured. Okay. Yeah, so we have this gentleman by the name of Eko Banda, a fisherman born on the 21st December 2000, went to a facility called Luangwa Memorial Center on 4th January 2021 with complaints of fever, swollen lymph nodes, and generalized body pains. After registration, he was assigned to HTS for counseling and testing. His results came out positive. He was referred to ART to seek HIV care and advised to come back with all partners for couple counseling. So the ART provider used the SMARTCARE IHAP form to initiate him on ART. Okay, so down here, there are actually the parameters that we have already gone through, the demographics, the medical history, the type of HIV, the medical history, the drug history. Just move on. Yeah. Drug history on the right. Okay, all right. Drug history, then there's the TB screening, presenting of complaints, family planning, physical examination. Eligibility for
my medicine on top of the fridge. Both my tablets, no.
Eligibility for TPT initiation, the plan, the prescription, the appointment is basically what we're going to see in the system. Then the story continues on page 2. They say on the same day, 4th January 2021, the patient locator form was filled out for Mr. Eko Banda. So again, we'll look at the patient locator, we'll fill it out. Let's move on. Entering details on all those forms. Then after 3 months, on 5th April 2021, Eko Banda came back for review, feeling much better. The ART provider used the clinical follow-up form to review him. Okay, so we'll also enter details about the clinical follow-up. Then finally, on August 5, 2021, Mr. Eko Banda requested to be transferred from Luangwa Memorial Center to Lusaka, where he continued his care at Chawama Level 1 Hospital. The provider at Luangwa Memorial Center filled out the patient status form. The provider at Chawama Level 1 Hospital filled out the patient locator and also the patient status form. So basically, we have looked at the paper forms. So now let's go into SMARTCARE. Not yet. Yes. So we'll start from the homepage. So we'll enter the name of the patient, the surname, and the first name and his gender. Then we'll search. So we have this client already registered for us, and we provided the HTC already. Because the HTC result was positive, you'll see a notification at the bottom saying tested positive but not yet enrolled. This client is tested positive but is not yet enrolled. So the objective of the ART provider is to actually get rid of this message or of this notification, so that you ensure that this notification stops coming out. So on the interaction history page, you can see there's the registration, which was done on the 4th of January. The HTC was done on the 4th of January. And then there is the one interaction that pops up automatically called the ACB, the Adult Case-Based Surveillance, or CBS. This automatically comes out for all clients that are HIV positive. So we'll go, this one is an adult, so we'll go to the V45 adult ART. Again here, let me just say that you remember we had the V45 and we had also the adult ART and the pediatric ART, then there was V45 PIDS. That was to take care of the forms. As the forms are revised by MOH, before they are brought to, when they are brought to the developers, before we implement them, we realize that in the facilities, there are some facilities that are still using the old forms. So we left the 4 ART modules, the V45 and the other ones open, so that if you were using the old form, then you would use a module that had the old forms. But later on, when we discovered, or when we were advised that all the facilities now were running the new forms, I'm talking about the V45, not this one, but the V45, we saw the V45. Then we got rid of the other 2 ART modules. So now we have got only 2, the V45 PIDS and the V45 adults. So for this one, we'll open this one. So you'll see the ART forms are listed there. Of course, the eligibility and initiation are going to be obsolete very soon, because now everyone is test and treat. So there is no eligibility, there is no initiation. Initiation is going to be done in the IAP. The short visit, again, from what I've heard, might be phased out because of abuse. It has been abused by some providers, such that because it's short, they would rather use the short visit than the clinical follow-up. Okay, I think Dr. Bosco will say more about that one. Then we have the patient status, of course, which are disabled because they can only be enabled when we enter the initial history and the physical form. Don't worry about the TB screening, the follow-up, and so on. So let's start with the initial history and physical. So we'll get the date. This is one common mistake that providers do. They click on OK when the date opens. When you click on OK, it means you are getting the default or the current date. The system defaults to the current date. So ensure that you go to the calendar and get the date when that interaction was conducted. So you click OK. Yeah, so this is the background. History 1 is where you enter either the care card number. If the client has got a care card and is connected, you just click on Get Card ID, then that number on the card will come and sit in this box here. Then you just put the ART number here. For example, 1, 2, 3, 4, 5, 6. So I can put my 6 there. Okay. In the new system, I know some of you have heard that this SmartCare has been re-engineered to SmartCare Plus. So the ART number is also going to be assigned by the server. So in the new system, it will be assigned the same way we assign the new pin by clicking on prefill, then the system will give. So even in the new system again, it will be like that. So we'll give the ART number here. Then the HIV test, this is the type, HIV test type. You have got HIV 1, 2, or 1 and 2, and the date when they were done, okay? So you can advise me, what HIV can I put for our echo banda? Anyone?
Put 1.
1,
Put 1.
thank you.
1.
Thank you very much. So 1, and it was done on the 1st and 4th January 2021. Okay. The recent test, again, that we said is a program, but the provision is already there. So it will be tested, and it was the result will show whether it is a recent test or it's a long term and the date when it was done. For now, I'll leave it. I just wanted to show you that it is here already. Then we'll go into the medical history. Okay, so the medical history, there is the current TB, yes or no, and if yes, the date when it was diagnosed is there, and also the mode of diagnosis. So I was talking about the mode of diagnosis. It is there, whether it was expert RIF, LF-LAM, microscopy, X-ray, drug susceptibility test, or expert MTB. So the mode of diagnosis is also here. If it is past TB episode, when was it done? And was it extrapulmonary or pulmonary? And was the ATT completed? Yes or no? If no, why? So that provision has also been put in the system here. And of course, the other diseases like the diabetes, the oral thrush, the ear discharge, sickle cell, cardiac, the diarrhea, asthma have also been included here. So you indicate whether yes or no. And if there are any comments, so the comments will be put in that box there. The issue that was done that mentioned that the spelling for drug is here. So this is drug history, but it was a typo, and N was put there, but otherwise it is there. So if the patient is currently on TB medication, so you say which month of TB course. Of course, here you want to know whether they are in the intensive phase or in the continuation phase. So if it is 1, for example, then the intensive. If it is 4, 5, they are in continuation and the drugs that they are taking. Then the TPT drugs are also here. So you have got your INH there, your 3RH, the 1HP, 3HP, other, and also the other drugs, including the herbal medicines, if they are there. The ARVs, again, for prevention, ARV exposure, you have the PrEP, the PEP, the PMTCT, and ART. Then you have the NRTIs for ARVs, NRTIs there, NNRTIs there. Again, this is what our colleague on the call mentioned. So this will be corrected. It's supposed to be ST, I think, something like that. The doggrapher and rotographer there. So that is on the drug history. Then we move on to TB screening. So again, we have these symptoms, which are TB-related symptoms. So if no symptoms, check for TPT eligibility. If symptoms are present, evaluate for TB. Again, there was a typing error here. It's supposed to be if symptoms are present, evaluate for TB. If no symptoms, check for TPT eligibility, which is not very difficult to control, to change. So this one will be changed. So again, then you tick if patient mentions any complaint listed, note duration, recurrence in adjacent box. So if you say fatigue is present, then you say the duration and the recurrence in these boxes here. So this has also been provided. Review of systems. So the review of systems starting from constitutional, the gastrointestinal, the genitourinary, the cardiorespiratory, the neurological, all those and other have also been provided here. Like I said, it was at the end of the program, and people were rushing to meet the deadline to have the deliverable done, and so it is not final. There will be some corrections that will be made here and there. On the family planning, the additions of the emergency pill, the permanent, the vasectomy and BTL, the intrauterine device, natural family planning method have also been included here. And that question of saying, if no, does client need family planning? Then if yes, refer for family planning. So that one is also taken care of. The pregnancy, if the client or patient is currently pregnant, has the patient been screened for syphilis in this pregnancy? So yes or no, and yes or no. If syphilis is present, have they been given penicillin? Yes or no. Of course, with that feedback that came from the paper form, we'll advise or we'll wait when the implementation is done, then we'll add the other, because if penicillin is not there, it doesn't mean this person cannot be treated, but they can be treated with something else. Then the cervical cancer screening is also there. And then there's VIA and also the other type, which is HPV DNA, has also been included. Then we go to the physical examination. This physical examination, you have your general condition there, whether it is pallor, jaundice, edema, or cyanosis, it is added there. Then the vitals, the height, weight, the BMI, obviously it calculates automatically once height and weight are entered. Okay, the head circumference, the MOH, the heart rate, and those bedline or bedside, I'm not too sure. Yeah, those results, if they are there for RST, the HbSAg, the pregnancy and urinalysis are also entered here. The WHO clinical staging, there's 1, 2, 3, and 4. So the WHO staging for that day will be entered. Then on the assessment, you have seen there's supposed to be assessment here. There's presumptive TB and presumptive STI. It is under assessment. And then the examining of the patient from head to toe is done at the bottom here. Then we have got the labs. So the labs with those additions that we saw on the form, the serum, the CRAG, the expert MTBRIF, the HbSAg, all those have been included, including the LDL, the HDL, all those are also included on the lab results. Then we have our eligibility for TPT. So if this person is eligible, has the client taken TPT in the last 3 years, yes or no? Is the patient eligible for TPT today, yes or no? If eligible, have you provided TPT today, yes or no, or not applicable? So this one is also taken care of here. Then you have your plan. On the plan that we said has got the EAC, has got the starting ART, has got the LF-LAM, has got the disclosure, was it disclosure counseling? Is it here? Does the patient have advanced? Okay, so all those additional issues on the plan, including DSD, I'm sure. There should be DSD. Okay, starting in DSD, community or family, you continue DSD or transfer to mainstream. All those are taken care of here. Then you have your advanced HIV care. Does the patient have advanced HIV care? If yes, has the chest X-ray been done? The LF-LAM have been done. And also there's another test. I think the cryptococcal antigen test. Again, there was a typo here, which can be advised, advise the developers in the new project to, yes, to include it. Yes, so there are investigations at the bottom. If you now as a provider, you want to see the viral load in the next visit, or you want to see CD4 count in the next visit, then you order from here. If there is TB, maybe resistant TB, for example, TSR, you can order LOF LAM there. It is now there. There are also other advanced tests to be ordered. Then referrals, okay, with those additions of the ESC, the CETA, all those are also added on the referrals. Then last but not the least, I'm sure, it should be prescription. Yeah, so the prescription, it's not done the way it is on the form, unfortunately, I must confess, because I think time finished for them to implement the first line that is on the paper form. You saw it has got the Otagrava, the other one has got Tafed, the other one has, I think, has got the Efavirenz, which has got 400 milligrams on the paper. But here we still have the odd one. However, it can still be searched, okay? It can still be searched and it can be found. Whether it is TLD or TLE, it can still be found and put as a prescription. So basically, that is how the implementation has been done in the system. Thank you. Over to you, Dr. Zam.
Very, very interesting new additions, and we thank you for taking time to come and share with us these important changes that have happened. I would like to believe even the network is just as happy to learn some of these important changes. So I think we've already completely run out of time. We are 2 minutes past the time. But I'll just accommodate one or two hands that have been raised. I've seen there's Mary Mlenga from Howard University. Please go ahead, unmute yourself and ask a very, very short, quick question so that we can respond to it. Mary? Chatonda, they have to unmute themselves. You can unmute yourself, Mary. Yeah,
good afternoon. Thank you very much for the presentation. We have very interesting additions, which is very good, and I think it will improve on our quality of service that we are providing to our clients. On the plan, I am just wanted to find out. It says start DSD, and one of the models put there are family and community. I want to find out if it's family or it should be facility. If it should be facility and community, will it be okay to have a drop-down menu that will give us the type of models that are there under facility and under facility model? Thank you.
Thank you very much. Very, very important inclusions. I think as a program, we should be able to make that recommendation. And as the developers, I don't think there is a problem with them in including that. So we should be able to make this submission in the next reviews that we're having. Thank you very much for that important comment. And I've seen there's a comment here that we need to include a component of genotype results as well here. And I think this goes with what Dr. Thomas had said, that we need to have a provision for resistant testing and the results for decision making. Yeah. So I think there's quite a lot that we're still learning. This is just introducing all of us to the new forms. There's still quite a lot of work we need to do. We can't finish everything in this particular session, but just for us to know that this is now happening, like you heard from Dr. Bosco, this should have started quite early on. We actually, if we don't have these forms, then we're actually late. So I think in wrapping up, I don't know if Dr. Sibylla would like to make a comment, one or two, on this particular session that we have had. Dr. Sibylla, are you on the call? I think maybe there's a challenge there. Dr. Bosco, would you like to just make some final remarks on this, on the forms?
Thank you very much, Zambo. Thank you, everyone. Just one key information, whatever, remind again on the short visit. I know it is being widely used, but we don't have it anymore. Short visit have been removed. Let's not be using short visit anymore, please. Number two is the summary sheet. The summary sheet, the HIV summary sheet, we have a very nice HIV summary sheet which has every element there, including the date of next viral load test to be done, including the date the test was sample was collected. Lastly, not the least, the patient locator. We are losing patients and we can't trace them. We can't track them because the addresses are not being updated. Please let also, as we see patient every day, let us verify the patient locator, update the address or revise if the patient have shifted. So those are the few remarks I wanted to add in the for this presentation, and thank you very much for the good presentation. Thank you. Over.
We appreciate your support, Dr. Bosco. Thank you very much. And we want to thank Tommy for having been available to just run us through this important session. I know we squeezed you. Ordinarily, you would want to have more time. You were rushing, but I think this is just a preamble to what the program is introducing. And we really appreciate the comments coming in from the network, and we will definitely use them to improve the SMARTCARE forms. I think that being said, I would just like to say thank you very much. Next week, we have the provincial-led ECHOs, so just look out for notices to your, which will be specific to your provinces, and particularly for the Southern, Eastern, Western, and Lusaka province. You have your own ECHOs as we continue to work with the Northern region provinces for next week, and we'll be looking at cervical cancer screening as one of the topics for next week. So till we see you again next week, do have a lovely day, and bye-bye.
Thank you.
Thank you.